chest pain. So chest pain is a very common symptom that you will see in clinical practice. So let's start with how to differentiate between different kinds of chest pain. First, we will start with the mnemonic that is used to ask questions regarding chest pain from patients. So as for any type of pain, we will use SOCRATES, Socrates. Okay, these are total 8 symptoms that you have to ask patient that you can learn by or remember by Socrates. First, starting with S. So S means sight. Okay, so you have to patient what is the site of pain. The patient must use one finger to point the site of pain. Then secondly we have O. O is for onset. How did it started? How did the pain started? How did it come on? Okay, this means history of presenting complaints. Third, we have C, that is for characteristic or character. Okay, sorry, that is character. For example, dull or aching or tearing or stabbing pain. You have to ask what kind of pain he is having. Then fourth, we have R, and R is for radiation. Ask patient if the pain is radiating to any other part. Does the pain move or spreads to elsewhere? This is for R. Then we have fifth point, that is A. A is for associated complaints. So usually associated complaints are the ones that helps in diagnosing a case. Okay, so you must ask what the patient is having with the chest pain. Is he having nausea or fatigue or anything else? Sixth, we have T. T is for timing. Timing is very important. Duration or pattern of pain. Okay, then we have seventh is E. E is for exacerbating factors. Okay, what provokes the pain? Okay, and what relieves the pain? So this is for E. Then we have S, which is severity of pain. So you have to make a scale and ask patient to mark his pain severity from 1 to 10, 10 being the worst pain imaginable. Okay, so these are the 8 points that you have to ask during a case taking of chest pain. Socrates. Okay, site, onset, character, radiation, associated symptom, timing, exacerbating factors, and severity. Okay, so these are the chest pain symptoms. Now we will start with the differential diagnosis of chest pain. So first we have is angina. Okay, and it is more commonly, or the proper name is angina pectoris. Okay, so let's start with angina. Now, angina's pain is caused by myocardial ischemia. Okay, the stoppage of blood to the heart. There is ischemia in the circulation, so circulation is abrupted to heart, and it is felt over the central part of chest or central part of anterior chest. Okay, and can radiate up to the jaws. It can radiate up to the jaws, to shoulders, or down the arms, or it can even radiate to umbilicus. Okay, so here I will draw a diagram so you can remember it more easily. So this is our face, if you must follow. So here we have ears and umbilicus. So the pain of angina is felt in anterior chest, jaws, shoulder, and down the arm and umbilicus. Okay, so usually it is felt more on left side because heart is tilted towards left side and anterior chest, obviously. Okay, sometimes what happens is there is no symptom but only pain in jaws and down the arms. Only these two sides of pain are present in angina, so you have to be careful regarding the diagnosis. Okay, now we have the patient complains of discomfort more than the pain. Okay, so there is a crushing, like tight sensation in the chest, anterior chest. There is a sensation of heaviness. And this sensation is worse from physical or emotional exertion. So you may have seen in movies, whenever someone heard the bad news, they suddenly suffer from angina. So that is emotional exertion, and also can be worse from cold weather and after a meal or after eating. Now the classical situation of angina that you will see the picture in books or also in movies, patient clenches the right fist and holds it close to the chest. Okay, so this is the classic situation. If you see any patient doing this kind of maneuver by their hands, then you should suspect angina. Okay, so this is about angina. Now our next differential diagnosis for chest pain includes myocardial infarction. Okay, so what is difference between ischemia and infarction is that in ischemia we have decreased circulation of blood to the heart, but in infarction there is absent circulation to the heart. So this is a heart attack. Now the pain is similar to the angina. The pain is very similar to the angina, but it is more persistent despite GTN spray. So if the patient is having angina attack, you give GTN spray, then he is relieved in few minutes. But the patient will not be relieved with GTN spray in myocardial infarction. Third, we have pedicarditis. Okay, so let's see. Constant retrosternal soreness. Okay, there is sensation of soreness. This gets worse on inspiration, on inhaling, and it gets better when sitting forwards. Okay, so this is about pericarditis. Now we have esophageal spasm, right? So esophageal spasm is not very severe, but you will detect it sometimes with the obvious history of dysphagia or difficulty in swallowing, or odynophagia, that is pain during swallowing. So we have retrosternal burning pain. Retrosternal burning pain. So this is our sensation and our sight. The onset is usually after eating or drinking. There is always a history of dysphagia in esophageal spasm. Okay. May be relieved with GTN spray. Now you see, GTN can spray esophageal spasm and it can also relieve angina. But how will we tell the difference that what we have treated with GTN spray? Was it angina or was it esophageal spasm? So there is one simple method to know that. GTN spray, when given in esophageal spasm, then it relieves within 20 minutes. Okay, it relieved the esophageal spasm, burning pain sensation in 20 minutes, and it relieves angina in few minutes only, and it does not cause relief in myocardial infarction that suddenly. Okay, now our next differential diagnosis is gastro esophageal reflux, or GORD or GERD. So this is heartburn, which is actually very common, especially in country like India where we constantly eat spicy food. So there is retrosternal burning pain. It is relieved by antacids. Onset after eating. Okay. Next we have is dissecting aortic aneurysm. Okay, so in dissecting aortic aneurysm, what we have is there is severe tearing pain which is felt in the posterior part of posterior chest. Okay, so angina we have anterior chest, and in aortic aneurysm we have posterior chest with tearing pain between the shoulder blades, classically between the shoulder blades. There is history of hypertension if you look up into the case. Then lastly we have pleuritic respiratory pain, pleuritic pain or respiratory pain. So this is a sharp pain which gets worse on inspiration. Okay, pleuritic pain is very sharp pain that gets worse on inspiration, and coughing. Okay, whenever intrathoracic pressure is increased, and this is not central, this is located to one side of chest or localized to one side of chest. There is no radiation of pain and no relief with GTN spray. So this is about all the differential diagnosis of chest pain. Okay, so we have last one, that is musculoskeletal pain. So this is very obvious. So you will find like a fracture or an injury at the site of pain. So that is like a mechanical, they have a cause, injury, fracture, or even chondritis. So they have a cause for pain. It is very well localized to a particular spot. Okay, this is worse by movement and respiration. So let's wrap it up. These are our differential diagnosis for chest pain. Okay, let's have a quick revision. So first we started with the chest pain, and we have to remember Socrates to learn about what to ask in a chest pain. We have site, onset, character, radiation, and all the other questions. Then we have angina, discomfort more than pain. Patient clench their right fist to their chest. Then we have here is myocardial infarction, pericarditis, esophageal spasm, and here we have gastroesophageal reflux disease or GERD, dissecting aortic aneurysm, pericarditis, and musculoskeletal pain.